So now John Messenger, who's been very, very involved in leading the National Cardiovascular Data Registry, is here to give us an update in your hometown, John.
Great. Well, thank you to the organizers for inviting me, and it's very hard to follow that kind of talk of pie in the sky of doing PCI remotely across the internet. But I'm going to try to summarize some of the things. I think this is a good session for this to be in because we're going to follow up the imaging modalities and how we are integrating imaging within the national registries. And today's topic is on NCDR update, focus on CathPCI version 5. My disclosures are here that I chair the Science Quality Oversight Committee and chaired the version 5 upgrade, so you can direct any complaints once it comes out to me. Deepak Bhatt basically summarized this and how we're using the registries. You know, when the initial registry started, they focused on quality improvement in the cath lab. Nowadays, through the work with multiple grants and the DECIDE grant through DCRI and multiple other partners, we've taken the database information and have been able to link it with other data sources. So allowing us to do pharmacologic studies, allowing us to do longitudinal studies, and this has been borne out across all the registries. But the whole goals are quality assessment, quality improvement, and then clinical research to help improve outcomes and drive that. So that's sort of the background of this. So many of you know the CathPCI registry started in 1998. Initially, it was less than 100 sites in the first year or two, but this basically is the collection of detailed information about the clinical aspects of the patients, processes of care and outcomes data on patients undergoing diagnostic cardiac catheterization and PCI. Now we're at about 1,740 hospitals in the United States. This represents, we think, somewhere in the order of about 85 to 90% of all hospitals performing PCI in the U.S. Sky joined as a partner with the ACC on this registry, and the ACC registries all are very similar in NCDR. They have steering committees, and then they have research and publications committees. The steering committees are charged with operational and strategic oversight, updates and management of the registries, and then the research and publications committee really enact the strategic research priorities. They have a pipeline of research that they review and actually have annual budgets to fund both investigator-initiated and strategic manuscripts with that. There is, though, some fatigue with version 4. Version 4 was implemented in 2009. This was the last update that we had done. The first 3 updates all happened in the first 10 years of the registry, so there was fairly rapid iteration. But 2009, we've been sort of languishing with this. One of the key challenges is all of the information that was presented here earlier has not been captured reliably within version 4, and we're missing many key elements for the appropriate use for PCI. We have none of the elements for appropriate use for catheterization. Many of the key elements are missing for appropriate risk adjustment for many of the important variables, particularly bleeding risk models. And then we've largely exhausted many of the research questions that we can answer within this because we haven't had any new data elements for about the last 9 years. So the goals of the CathPCI version 5 update were to support quality assessment and improvement initiatives, accurately capture patient risk variables. The AUC for Cath and AUC for PCI were done concurrently with this process, or at least as closely as we could do that, so that we could map the diagnostic procedure variables for both of those in parallel. These are being redesigned for improved data flow and workflow capture, and we're now going to capture novel patient and procedure information that's really going to help us, I think, ask a whole new set of questions. In addition, these are fairly responsive, and we're now providing modules to allow longitudinal follow-up for patients that will help drive our 30-day readmission rates and some of the targets that were being set up by CMS and MACRA. So the AUC for Cath and PCI, one of the big keys is documentation of ischemia. That's critical for AUC. Version 4 only captures FFR data or IVUS data for intermediate stenoses only if PCI is performed. So if you code the stenosis above 70%, none of the information is available for appropriate use criteria. So just understand fundamentally right now, until we put this version in place, IFR and FFR have no actual measurable effects on our appropriate use. That's why this is such a critical change going forward. Also, deferring PCI is a huge issue for appropriately using these technologies, IFR, FFR, IVUS, to not perform things and to actually demonstrate at hospitals that they're using these technologies appropriately. And then OCT and IVUS are obviously fairly new, and we'll be able to capture those. In addition, upstream imaging through new technologies with CT, fractional flow reserve, and potentially angiographic flow reserve are also going to be captured going forward in this. Diagnostic cath is not very sexy, but the insurance companies are highly focused on this, and one of the big challenges is we've been unable to demonstrate the appropriate use of diagnostic heart catheterization because of the lack of granularity. I think all of us come back to this. We as a transplant center have been unable to demonstrate that transplant patients have an indication for heart catheterization. So we're going to capture this as solid organ transplant evaluation, subsequent surveillance, and importantly, cardiac surgery is not an indication for heart catheterization that has been captured previously, where we all know that we do this routinely per the guidelines, but that's going to help be solved with this version 5 update. We've streamlined the coronary anatomy and made it simpler, particularly for people who don't have obstructive coronary disease, greater than 50% in 2 millimeter or larger vessels where they can just check no. But we've basically made it so that you can capture adjunctive measurements regardless of the native vessel percent stenosis and in grafts, which we've been missing previously. The great lead into this is that if many patients coming to the cath lab do not have a prior evaluation for ischemia, and this is about 40% of patients undergoing PCI as outpatients have no documentation of ischemia. What you notice here in the slides is that the ability to demonstrate and record an FFR less than 80, 0.80 makes it at least that these may be appropriate and certainly positively impact single vessel disease in stable ischemic heart disease, making it more supported by the guidelines. Decision-making around complex procedures and revascularization particularly has been a huge issue. We are going to capture frailty similar to the TVT registry supported by STS and ACC, trying to leverage that and harmonize these data sets so that we're using the same frailty measures across these registries. Patients who undergo concomitant procedures, TAVR, valvuloplasty, alcohol septal ablation, LAO occlusion, these are going to be captured in more granularity because we're seeing more hybrid or more procedures where these are being performed at the same time. So we need to risk adjust those cases accordingly. And also we'll be capturing much more granular data about arterial and venous access sites, particularly as we move around, in particular crossover, which we've not been able to do. The Canadians have developed a frailty scale that's going to be used and piloted within this. I was involved in the ASSERT study, as several others here were, and this bottom graph is the propensity to receive PCI or bypass surgery. And what you notice is the only people we did in the propensity models were the middle half of this graph. We are very good at selecting patients for PCI and very good at selecting patients for bypass, but we have no ability to measure that within our current registry. So we're introducing decision-making in terms of a heart team approach and whether surgery was recommended or not, whether patients declined, so that we can, again, get at some of this granularity on why there may be differences between PCI and bypass surgery. Shock and cardiac arrest, very important areas. Obviously, we're capturing more granular information. The ACTION registry is undergoing a version upgrade at the exact same time as CathPCI is, and so we're harmonizing the cardiac arrest information from that to be more specific about the timing, particularly about withdrawal of care. All of this cardiac arrest data should help us improve our capture around these complex patients, whether or not therapeutic hypothermia was included, what's the level of consciousness. Again, none of this stuff has been available for us to use in risk models because we just really didn't have the granularity. And I think this will help all of us, particularly as we identify patients who are eligible for not being considered for public reporting. Clinical instability, right now we don't capture timing or the type of mechanical circulatory support. We're going to improve that. We're going to integrate that into the bleeding risk models, which has been missing. And then we're going to provide follow-up modules. The follow-up modules are all optional for sites. This can be used, however, they aren't counted in terms of the data quality, in terms of submission records for the data quality program for NCDR, but will allow us to capture things like Seattle Angina Questionnaire, CHF symptoms using the Rose Dyspnea scale, and then some aspect of outpatient medications going forward. So in summary, CathPCI version 4 will be released in early 2018. All of you will be, I'm sure, hearing about this from your data abstractors as you go forward, because I do think that this is a higher burden of data collection, but I think it's critically important time for us to be capturing this more granular data going forward. It's going to provide information necessary for both AUC for Cath, which is we're being asked for by our insurers, and for PCI, importantly, for documentation of care. We're going to better characterize patient selection, particularly around multi-vessel PCI and surgical turndown in a high-risk group of patients. This will help us also with cardiac arrest and cardiogenic shock, which are very controversial as we've entered the era of public reporting. And this has been designed from a software perspective to be much more able to be modified on going forward. We have accessory data fields that can be implemented, and we're going to have a much more dynamic data registry where many of the definitions reside within the data dictionary, which can be modified in a much faster fashion for implementation. So thank you very much, and thanks for coming to Denver.